As part of the newborn physical assessment, we use growth charts to plot an infant's weight based on gestational age to determine intrauterine growth and classify the infant's size as appropriate for gestational age, AGA, small for gestational age, SGA, or large for gestational age, or LGA. So SGA is defined as a birth weight less than the 10th percentile, and LGA infants weigh greater than the 90th percentile for gestational age. So we have here the Lubchenco or the Colorado intrauterine growth charts. This was made around in the 1960s. So based on the gestational age and the weight of the patient, then we are able to classify. However, this has limitations. So in around 2010, the Olsen chart was formulated. Okay, so this because the the observation was the Colorado growth chart tend to underestimate extremely premature babies and tend to overestimate LGA babies. So they did the Olsen chart to address those problems, but we are still using at the moment the Colorado growth chart. So based on this chart, we're able to determine whether a baby who's born delivered premature is small for gestational age, appropriate for gestational age, or large for gestational age. So a preterm newborn may also have IUGR, as we've mentioned, or intrauterine growth retardation. So most growth retarded infants have asymmetric growth restriction. First, there is restriction of weight and then length with a relative head sparing effect. So examples of this would be due to extrinsic influences that affect the fetus later in gestation, such as preeclampsia, chronic hypertension, and uterine anomalies. So when you have intrauterine growth retardation, you have a small for gestational age baby. However, the head size is spared. So the head size is normal. So in effect, it would imply that the insult occurred later in gestation because the head was spared. In contrast to symmetric growth retardation, when the insult has occurred early in gestation and therefore the head size is also affected. Okay, so uh, it affects all growth parameters in the human brain. Most neurons develop prior to the 18th week of gestation. So early gestational growth retardation would be expected to affect the fetus in a symmetric manner and thus have permanent neurologic consequences for the infant. So examples would be insults such as a genetic or chromosomal causes, early gestational intrauterine infections such as torch infections, and maternal alcohol use. So, in terms of outcome and prognosis, if ever a baby or a premature baby is delivered uh, with intrauterine growth retardation, a better outcome would be expected with asymmetric because there has been head sparing and brain development has not been affected. Now let's go to the NRP or the Neonatal Resuscitation Program. Okay, so this has been formulated by the American Academy of Pediatrics and is actually the standard globally for the care of newborns once they are delivered. And this is also used whether for term or preterm babies. So we have here in the chart the algorithm. It's composed of interventions as well as assessments. So the box would correspond to the interventions and the diamond shape would respond to the assessment that you're going to do. This is time bound. Okay, so this is what we use whether we're here in Cagayan de Oro, in Manila, or in other parts of the world. So this is standard for a resuscitation of the newborn, whether term or preterm. Now, in the Philippines, because we are trying to incorporate also other programs into the care of the newborn, this particular NRP or neonatal resuscitation program has been um, modified and is now called the NRPH. So, aside from the NRP protocol, the NRP program, it incorporated the concepts of kangaroo mother care and the EINC, or the essential intrapartum care of the newborn. So this is usually a 2-day course. So for our purposes, we're just going to run uh, through this. So we have here, so once a day baby is delivered, so you have a set of actions, interventions, and assessment once a baby is delivered, depending on the presentation. So for example, uh, upon birth, you have to assess whether the baby is term, or the tone is good, or if the baby is breathing or crying. So because we're talking about prematurity, so therefore the baby in a particular instance would be delivered preterm, and therefore we proceed to the next step, which is maintaining warmth and normal temperature. We position and clear the airway and clear it of secretions, and we dry and stimulate. So if the baby is term with good tone, breathing, and crying, then we usually go to the routine newborn care. And if the baby eventually, even with the initial steps that you did upon delivery of the baby, such as warming, positioning, clearing of secretion, stimulation, and drying, the baby still is apneic with gasping respirations, or the heart rate is below 100 beats per minute, then we proceed to the next step and we administer PPV, or positive pressure ventilation, or more commonly known as ambu bagging. Okay, then we monitor the oxygen saturation, and we may consider ECG monitor at that point to monitor the heart rate as well. Okay, if the baby is not apneic, gasping, or the heart rate is not below 100, however, the baby still is with labored breathing or persistent cyanosis, then we proceed to the steps of positioning and clearing the airway. Maybe because the airway is just obstructed, we monitor the oxygen saturation, and we may give supplemental oxygen, or we may consider giving positive pressure or continuous positive airway pressure in the form of CPAP. Okay, so if the patient still has a heart rate below 100 beats per minute, we might have to check the chest movement and do ventilation corrective steps, because in a lot of cases, the heart rate of a newborn may not be improving and may not be increasing because there is just a problem in um, the institution of the measure, such as you might not be doing properly the positive pressure ventilation. So we check and we assess whether the heart rate is below 100. Okay, if it's still below 60 beats per minute, we might have to intubate. If you've already done that, we have to administer chest compressions at this particular time, and we coordinate the ventilation, that's the positive pressure ventilation, with the chest compressions. We have to give 100% oxygen, and of course, we monitor the heart through an ECG machine. If it's still below 60 after that particular intervention, we might have to give medications at this point in the form of epinephrine. So it's a step by step process of doing intervention and assessing the patient once a baby is delivered. So we assess, if we check the collar, we do the initial steps. Heart rate is below 100. We do positive pressure ventilation. Not improving, it's below 60. We give chest compressions. Not improving still, then we might have to give medications. So this is, I've said, applicable to babies delivered, whether term or preterm. So in your clinics, you might come across this, or definitely you would come across this. As I've said, it's now incorporated in the Philippines. This program is incorporated with the kangaroo mother care and the essential intrapartum neonatal care. So now we go to preterm newborns. As we've said, part of the initial steps once a baby is delivered would be provision of warmth, because it's very, very important that we are able to maintain normal temperature of the newborn, particularly among preterm babies, because they tend to lose a lot of heat. Okay, especially for preterm babies, they have a problem with thermoregulation, and we have the concepts of how uh, heat loss is being happens, or the mechanics or the dynamics of heat loss. So there are four ways there by which heat loss can occur in a newborn, especially in preterm babies. So heat loss is may be noted in cases of evaporation. That's why once a baby is delivered, we have to dry, because a baby upon delivery would be moist with amniotic maternal amniotic, or the amniotic fluid. Okay, so we have to dry the baby with pre-warmed linens. Heat loss may also be noticed or observed in cases of conduction if a baby's body comes in contact with a cold surface. So you therefore, prior to delivery, when you prepare the equipment for resuscitation of the newborn, you have to use pre-warmed linens. Or a baby may come in contact with um, air drafts, okay, cold air, and that is heat loss through the process of convection. That's why once a baby, or prior to the delivery of the baby, we turn off the air conditioning units in the operating room, in the labor room. And the process of radiation, whereby a baby may lose heat n- if the baby's body or skin comes or is not necessarily in contact with a cold object, as in conduction, but it is near a cold object. So that means you have to place your warmer or the crib when you receive the baby not very near a cold surface, such as cold walls. Okay, because heat loss may be observed through the process of radiation. So with cold stress, because seemingly making the baby's temperature go down to hypothermic levels, it may seemingly be not so consequential, but sometimes it may result to death. Okay, how does that happen? Because with cold stress, there is release of norepinephrine to stimulate brown fat metabolism to generate heat. There's also decreased surfactant production. There is also increased anaerobic metabolism and increased metabolic rate. All of these events would eventually lead to the following. It may lead to hypoxemia and acidosis or acidemia. It may lead to decreased oxygenation, eventually leading also to hypoxemia. Cold stress may also result to hyperbilirubinemia or jaundice and hypoglycemia. So it's